Good afternoon, everybody. It is nice to have our in-person crowd, as well as I see we've got a lot of you on the virtual grand rounds as well. It is my distinct pleasure to invite Dr. Alice Lichtenstein to give our grand rounds today. Dr. Lichtenstein is no stranger to all of us, or to many of us here, because she has had quite a lengthy career in the Department of Nutrition, in the School of Nutrition, and in the HNRCA. So Dr. Lichtenstein obtained her undergraduate degree at Kernel and received her master's and then her doctorate at Harvard School of Public Health. She has been on the faculty here at Tufts since probably the late 80s. And is currently a senior scientist and director of the Cardiovascular Nutrition Laboratory and the Gershoff Professor of Nutrition Science and Policy at the Friedman School of Nutrition here at Tufts, here on the Boston campus. Dr. Lichtenstein's lab has focused extensively on nutrition and cardiovascular risks with a broad portfolio of basic research, population-based research, with over 400 publications. She has received many accolades over in her career with over 400 publications. She has served on multiple committees and chaired multiple committees, both with the American Society of Nutrition, the U.S. Department of Agriculture at HHS, and with the National Academies of Medicine. She currently is a member of the Food Forum there, has been a member of the Standing Committee on Evidence Synthesis and Communication on Diet, and has served as chair of the Guidelines Advisory Committee to the Department of Agriculture, Department of Health and Human Services. She has received an honorary doctorate from the University of Kuopio in Finland, but many of us know her because of all of her mentorship and support of our career development programs. She has served as the chair of our internal advisory committee for our CTSI KL2, and has served as a mentor and an advisor on our Birch Award, and has provided a lot of guidance to and mentorship to our early career investigators. So it is a distinct pleasure, and we're looking forward to your grand rounds this morning.
Okay. Thank you very much for that very lovely introduction. How are we going to get my slides on? Up. Just next one. Okay, all right, great. Well, it's nice to be here, and it's really nice to see live humans, and it's also really nice to be able to talk without a mask, because this is probably the first time in over a year and a half is for all of you. Anyway, what I'm going to be doing is presenting the 2021 updated dietary guidance to improve cardiovascular health. It's a scientific statement that was released last Saturday, so it's a little under a week. And also talk about maybe some of the things that we could actually do at Tufts and address some issues that may come up, and hopefully provoke some questions. So anyway, just by way of background, hopefully we can all agree that poor diet quality is strongly associated with elevated risk of cardiovascular disease, morbidity, and mortality. So that's where we're starting. One of the things we know about diet in the United States is that we're not doing particularly well. So these are diet scores, and it's out of 100. And yeah, I mean, kids and older adults are doing a little bit better than everybody else, but given it's out of a score of 100, we're not doing particularly well, even though we've been trying for quite a while. And we also know what the problems are. We know that people are under-consuming vegetables, they're under-consuming fruit, they're under-consuming dairy products, they're under-consuming fish, they're under-consuming whole grains, and they're going gangbusters with things like refined carbohydrate. Again, these are just opposite of the messages we've been giving people, but this is what the current situation is. Our American Heart Association dietary guidance, we can't say guidelines, it has to be guidance, was last issued in 2006. So it's been 15 years. And it was because, and I've been asked, well, why suddenly now? We've sort of been thinking about it for a long time. And the bottom line is that the evidence has really accumulated. However, we tried to think outside of the box because if you try to think about how well we did between 2006 and 2021, it's been not great. Anyway, the focus on this new statement is on dietary patterns. It's not on individual foods, it's not on individual nutrients. And we're defining dietary patterns as the sum of all the foods and beverages we consume. One of the advantages is that it's adaptable to personal preferences, ethnic and religious practices, and life stages. Clearly, we know when people make radical changes in their diet to improve it, healthy diet, we know that they don't stick with it. So we've got to really take a very different approach. And it's food-based to facilitate implementation. So there are no target values for this or target values for that, which are very difficult to accurately calculate anyway. There are certain basic things to mention. We underscore the critical role of initiating heart-healthy dietary habits early in life and actually preconception. That this is not something that, when we don't want to give people the impression, this is something that, well, you're told you have an elevated LDL cholesterol level, your brother had a heart attack, and suddenly you're worried about it. One of the other things that I think is important about this set of guidance is that there's a lot of common elements of all the named diets, whether it be the Mediterranean diet or the DASH diet or the USDA diet. If you peel away all the layers, there are really some very basic tenets, and perhaps we should focus on that as opposed to saying, well, follow this pattern or that pattern. There are benefits of heart-healthy dietary patterns that go beyond cardiovascular disease, so it's not as though you're competing with another specialist that they're telling the patient to do one thing and then the other thing. And heart-healthy dietary patterns are consistent with sustainability and environmental health. And we know certainly the past 2 weeks with the Glasgow talks, that is coming up more and more. And for some people, that actually could be a motivator. And then the emphasis really for this guidance, it's on prevention. We're not talking about treatment here, we're talking about prevention. So what are the dietary guidance? Well, essentially we've organized them into 10 features, and spoiler alert, you're not going to be too shocked about these. However, the bottom line is this is what the data supports. So feature number 1, adjust energy intake and expenditure to achieve and maintain a healthy body weight. It's energy balance, it's food intake, and it's physical activity. You can't violate the first law of thermodynamics. And it appears with people's behavior that it really more has to do with food than with physical activity. A lot of emphasis, or we're recommending a lot of emphasis, be put on portion size and frequency. And this is because, again, if you're working with somebody with dietary patterns, you want to move them towards a healthier pattern. If you tell them they can't eat this or that, they're going to close down. But if it can fit into a pattern, if they just watch portion size and they maybe decrease frequency. We're also encouraging the adoption of a rapid diet screening tool into routine clinical care. And I'm going to say more about this because I'm going to put a challenge out here. We as the Tufts community, maybe we could actually be leaders in this. And there was a statement, a scientific statement from the Heart Association that hopefully one or two, some of you saw about that last year, but I'll go into more about later. Okay, feature 2, eat plenty of fruits and vegetables, choose a wide variety. Okay, the data from observational studies, intervention studies is there. Dietary patterns high in fruits and vegetables, better health outcomes. Is it the fruits and vegetables? Is it what the fruits and vegetables is replacing? Doesn't really matter. The bottom line is that's what the data consistently show. The deeper colored ones, that's the flesh, not something like a purple eggplant, although eggplant is fine, but the deeper flesh ones do have higher concentrations of essential nutrients, phytochemicals, and fiber. But then on the other hand, since we know people don't consume enough fruits and vegetables, we're not going to really split hairs about whether somebody's consuming, choosing romaine lettuce or kale or spinach. And we're really encouraging the use of multiple forms. Now we've got a lot of high quality frozen fruits and vegetables. There's this myth that frozen isn't as good as fresh. That's really a myth because frozen can actually have higher concentrations of nutrients, given that it's picked at the point of ripeness and it's actually processed in the same area. But if it's in the house, people are more likely to use it, to throw it into stir fries, to throw it in tomato sauce. We've got to give people sort of very practical, easy ways of increasing fruit and vegetable intake. Feature number 3, choose foods that are made mostly with whole grains rather than refined grains. Again, consistent data, dietary patterns that are higher in whole grain foods associated with lower risk. The beneficial effects certainly go beyond heart health, because something like the gut microbiota, if the more fiber, the greater both the alpha and beta diversity, which is associated with, again, better health outcomes. And the one thing that everyone needs to be aware of, you can't judge a bread by its color or its name, because you can have brown breads that are made primarily with refined grain and caramel coloring, and they can say multigrain bread, but they can still be made primarily with refined flour. So it's an easy thing to do. You just look at the ingredient list, and a whole grain should be the first one on the ingredient list. In terms of healthy sources of protein, we actually have sub-features. So this is feature number 4. The first is mostly protein from plants. That would be legumes and nuts. It's a good source of protein. It's a good source of fiber. It has a low carbon footprint, much lower than animal sources. And we do provide a cautionary note. You know that now there's a lot of the plant-based meat alternatives out there. They are ultra-processed. The original ones that got released were very high in sodium. They were high in saturated fat. There was no benefit in terms of calories. It's an evolving area. So this is just caution. You can't automatically assume because it's plant-based, it's going to be better. Sub-feature on protein, regular intake of fish and seafood. Dietary patterns that contain, fish and seafood, regular intake associated with lower risk of cardiovascular disease. Some of it may be due to the omega-3 fatty acid content. Some of it is probably due to the substitution if fish and seafood is replacing other sources of animal protein, red meat and full-fat dairy products. And you may also know that the data is a little uncertain now about the effect of fish oil supplements, but we know that having dietary patterns higher in fish are associated with better outcomes. And we'll see what happens when that all settles with the fish oil supplements. Also under protein, low fat and fat-free dairy products instead of full-fat dairy products. We are very aware that this is not without controversy. However, the bulk of the data indicates that one is better off choosing low fat, which is it's either 1% or low fat. They're two terms for, or fat-free instead of full-fat dairy products. We're not recommending a low-fat diet. That fat should be replaced with sources of unsaturated fat. So in terms of dairy, there's no good reason for choosing full-fat dairy products, and there's some reasons for not choosing full-fat dairy products. In terms of meat, if meat or poultry is desired, choose lean cuts and avoid processed forms. A lot of this data comes from substitution analysis, where you take out the red meat and processed meat, you put in other types of protein, and you look at dietary patterns. Now, it is a little bit frustrating. Sometimes we talk about red and processed meat, and the question is, why not just processed meat? And a lot of that is because the original databases and the original tools that were used to assess diet intake actually just adds a question about red and processed. Now, the updated food frequency questionnaires and all those things separated. Feature 5, use liquid plant oils rather than tropical oils, animal fats, partially hydrogenated fat. Again, robust scientific evidence to indicate that when you include dietary patterns that are higher in unsaturated fat, whether it be polys or monos, are associated with better health outcomes, particularly with cardiovascular disease, than saturated fat. Now, the data is strongest for polyunsaturated fat. So that comes from things like soybean oil and corn oil. Monounsaturated fat, it's a little bit more difficult within our dietary patterns as opposed to the Mediterranean. And that's because most of the monos in our diet come from canola oil, olive oil. However, in the United States, a lot of our monounsaturated fat comes from meat, and we're recommending that people tamp down on the meat and particularly fatty cuts of meat. So that's why when you see the data, you see it's so much stronger for polys than monos. But again, you want people to go away from things like lard and butter. So to argue between canola oil and olive oil is not worth it. Feature 6. Choose minimally processed foods instead of ultra-processed foods. This is one of the newer recommendations. And we know that food processing has some beneficial effects and adverse effects. Certainly pasteurization is a good idea. However, there's no standard definition for ultra-processed. There is the NOVA classification system from Brazil, but not everybody sticks to it when they talk about ultra-processed foods. But regardless, if you look at the data, those diets that are higher in ultra-processed foods tend to be associated with adverse health outcomes, and the data is very consistent on this. Feature number 7, minimize intake of beverages and foods without added sugar. Again, the data are really strong. I don't think there's any question about that. The issue is, how do you get people to decrease their added sugar intake? Well, the first thing is to note what the major sources are. So sugar-sweetened beverages, sweet desserts and snacks, and candy and sugar. So those are the obvious ones. But you may have patients actually that's not where they're getting most of their sugars. So you have to probe a little bit to see. It's also important for people to understand that added sugar has many different names. So sucrose, glucose, dextrose, fructose, and then you've got molasses, cane syrup, brown syrup, corn syrup, honey, maple syrup, and concentrated fruit juice, even if it's organic. Feature number 8, choose and prepare foods with little or no salt. Get direct positive relationship between sodium intake and blood pressure. This paper just came out this week in the New England Journal, and it's looking at large cohort studies, and this is 24-hour urinary sodium excretion. This is the only way you can get any idea of how much sodium someone's consuming. You certainly can't get it for a food record or recall or anything like that. And sure enough, there's a direct relationship, and with potassium, a negative relationship. Where do we get most of our potassium? From fruits and vegetables, which we're not eating enough of. Also reported in this paper, and you can sometimes see it, is to look at the sodium potassium ratio. I would say be very careful there, because if you start looking at just the sodium potassium ratio, you know what that sounds like? I can eat all the sodium I want if I just take a potassium supplement. That's not a good idea. So any time with ratios in diet, be very, very cautious. But anyway, this happened to just come out, so I thought I'd show it. So where are we getting our sodium? It's mostly from processed foods, and yeah, some ultra processed foods also. It's all over. And what I want to call your attention to here is this 19% here. Well, what does that represent? It actually represents salt that's added during cooking, salt that's added at the table, and then miscellaneous, which are things like certain water supplies actually have some sodium in it. So you can't just, it's not adequate just to get people to take the salt shaker off the table or even out of the kitchen. But it again has to do with trying to steer people towards minimally processed foods as opposed to processed foods, because it is absolutely all over the place. Feature number 9, if you do not drink alcohol, do not start. If you choose to drink alcohol, limit intake. We know there's a very complex relationship between alcohol intake and cardiovascular disease. From observational studies, and we have to understand these are observational studies, there is a J or U-shaped curve. And that, you know, that's sort of where the data are. Because the findings are based on observational studies, there could be confounding by other variables. It's very unlikely we're going to have a controlled intervention trial. So to be clear, the Heart Association does not support initiating alcohol intake to reduce cardiovascular disease or improve cardiovascular health. And, you know, given the uncertainties about the net effects and the deleterious effects that we're aware of. Lastly, feature number 10, which I think is probably one of the most important features in this day and age, and that's adhere to this guidance regardless of wherever the food is prepared or consumed. We procure, prepare, and consume food, lots of different places. And it has been accelerated with the pandemic between takeout and meal kits and food that's prepared in the supermarket that we bring home and eat. In the olden days, when you went out to dinner, it was once or twice or 3 times a year. It was a real treat, and we aren't going to tell people what they should or shouldn't be eating. However, that's not the case. We know at least 50% of the food dollar now goes to food that's not prepared at home. But all this guidance, dietary patterns, it refers to the entire package. So wherever the food comes from, it counts. It's important. The same way we know that if you eat broken cookies in a closet, it counts. It has the same number of cookies as outside the closet, but you can't get around. And then we do have a call to action, and that's just a general one about encouraging enactment of policies that make the healthier option the default option. And we have a very good public health example of that, and that's with hydrogenated fat, that first the New York City banned the use, then the FDA mandated that trans fat be on the nutrient tax label. I think it's highly unlikely to think that most people were aware of that or read that. However, that caused manufacturers to go through a major reformulation, and that's been well documented. And then eventually, 2 years ago, the FDA removed partially hydrogenated fat, the major sources of trans fat, from the GRAS list generally recognized as safe. So the default option is essentially the healthier option. We're sort of seeing that a little bit in sugar-sweetened beverages because at least now water is usually available when they're available, and we're seeing a decline, and there's also a massive public health effort. But the more and then the FDA last month did issue, they're asking voluntary reductions in sodium content of processed food from the manufacturers. Hopefully someday that'll become mandatory. But again, it's this idea that most people eat what's available, what's in front of them. If you put a basket of refined grain bread in a restaurant, that's what they're going to eat. If you gave them whole wheat bread, they'd probably eat that too. So the default option hopefully will eventually be the healthier option. As far as the AHA guidance, you can download this. There is a figure that summarizes it with the foods to emphasize, to minimize, and then tying it together on the bottom with energy, balance, and following the guidance wherever you're getting your food from. There are additional benefits to a heart-healthy dietary pattern. It meets all the essential nutrients for most individuals, so one doesn't need to be concerned about nutrient adequacy. It's rich in the healthy fats, unsaturated fat. It's low in saturated fat, trans fat, cholesterol, added sugars, and salt. So you don't have to keep track of it. Essentially, if you consume a heart-healthy diet, that's going to happen. There's benefits beyond heart health in terms of stroke, type 2 diabetes, kidney disease, cognitive function. So there are a lot of reasons to support it. And as I said previously, it is consistent with promoting a healthy planet. So why are we here? And have we made any progress over the years? So the bottom line is we haven't made much progress. This is the most recent data I could find, but this is out of 100. This is absolutely not great. So, what can we do? Why haven't we made progress? One of it may be there is a certain level of distrust in science. And this is from the Pew Foundation. They did a survey, and I identify with this because I consider myself a nutrition scientist, and only about half of the people have a mostly positive impression, which is not something that's particularly encouraging. Interestingly, so here's a graph, and along the x-axis is reliance on source, and the y-axis is degree of trust. Okay, so it turns out who gets the highest? As far as, whoops, there's something automatic about that. But anyway, who gets the highest? It's the health professionals. So it's this audience who can have the biggest effect. It's not somebody like me. So what can we do? What can you do? So this is the Rapid Diet Assessment Screening Tools for Cardiovascular Disease Risk Reduction Across Healthcare Settings. This is a statement that came out last year by the American Heart Association. And the concept is incorporating into regular clinical practice some monitoring of diet quality, putting in the electronic record so the next time you see the patient, you can ask them, you know, if you come up with something, they should change this, they should change that. Then you ask them, either they tell you they didn't and you ask why they didn't, or they did, and then you figure out something else. So there are a number of rapid screening assessments out there. I'm going to go through them real quickly because I don't think any of them is standardized. And I think that's one of the things where maybe we have an opportunity to actually do something. So there's one that's very rapid, and this is all comes just from the statement. There's one that's very rapid, and it's just 2 questions, but it's to get an idea of how engaged people are. Okay, you know, fruits, how many fruits, and sugary drinks. We don't have time to go through each of the specifics on this, and it's well documented. But you know, there's another one. It asks about frequency of quite a few different components of the patient's diet, and then you can sort of work with them from there. Then there's something that's specifically for the Mediterranean diet, and it's much, much longer, which means it takes much more time, which is not something that is probably particularly feasible, but that's out there. And then there's something called the REAPS-S, which is shortened, but it's still, it takes time. So there may be ways of condensing. This adds more about dietary behavior than pattern. So I'm just indicating right now, it's out there. There's no penultimate one, but there's an opportunity. And the whole idea, though, is incorporating it into the patient's electronic medical record so that there can be follow-up, because just asking people about diet and then not going back to it or not remembering what they said the last time is not what's going to be particularly helpful. This is adapted from a talk that Ann Thorndike, who's over at MGH, gave when these guidelines were presented, and it just indicates words matter, the way you talk to patients, you know, and these are the 10 features: adjust, plenty, choose, mostly, rather than, minimally, minimize, prepare, limit, adhere. That there's got to be some action words, and hopefully it resonates with whoever you're talking to. I just want to indicate a few things about sort of myths and cardiovascular disease to bring up, because it should be across the lifespan. However, people frequently think it's not a disease of young people. And of course, your designation of young and sort of your definition of older shifts depending on how old you get. But the bottom line is, you know, it's not just young people, but but we know it's a very slow disease. It takes a long time to develop. It really does matter what people do when they're young. And during the Vietnam War, when they did autopsies, it turns out there was a lot of fatty streaks in younger men. And that was one of, you know, a lot of the data came from that, showing that it's a very long progressive disorder, and it's important to start early. I feel very passionately about this, bring back home economics, although you can't use that term anymore. We really need to give kids from K to 12 the skills to understand the information. We talk about, oh, there's nutrient information on packages, there's nutrient information on the web, all over the place. And then there's an immense amount of nutrient misinformation, nutrition misinformation. Unless we give kids the skills to be able to decipher it, even after they go through their rebellious period, eventually they will become adults. You know, I think it's something that we should think about. We have, I guess that resonated with one person in the audience, but we have mandatory standards for food, school, breakfast and lunch programs. Why don't we have mandatory standards for food and nutrition? All people eat. It's not as though it's going to affect some people and not other people. Other myths: if I take a statin, I don't need to worry about what I eat. Obviously, that's not the case, but that's out there. Heart disease runs in my family. It's my genes. I can't do anything about it anyway. We have good data to show that's not the case. This is from the ERIC study. And what they did is they divided people on the basis of a genetic risk score, low, intermediate, and high. And then they looked at their lifestyle, most of which was diet. So if you had a low genetic risk score for coronary events, and there was a progression. If you had a healthier, more favorable lifestyle, you did better than if you had an unfavorable one. And it was the same thing with intermediate, and it was the same thing if you had a high genetic risk score. So it turns out if you have a high genetic risk score and you have a healthy lifestyle, you actually have a lower risk than if you have a lower genetic risk score and you have an unhealthy lifestyle. So, and this has been shown in multiple cohorts. So you can't use the excuse that it's my genes, I can't do anything about it. Another myth that people with heart disease should avoid eating raw fat. That is not the case. In the 90s, we kept recommending low-fat diets. We know with good intervention studies, that's not the case. In terms of body weight, there's absolutely no relationship between the percent of energy of fat in the diet and body weight. There was a very strong relationship in one of the major studies, the Pounds Lost study, that was between body weight and the number of sessions attended. It turns out that people that attended more of the study sessions were more committed to the diet, and they lost more weight, but it didn't have to do with the amount of fat. And as I said, there's multiple studies that have shown that. And then specific vitamins and foods can prevent disease. So it's the easy answer. You just have to take a vitamin E capsule and crack it open and dribble it over a hot fudge sundae, and you don't have to worry. Well, we have a lot of experience with that. It has not worked. And the literature is just strewn with this. And I probably here should have put high fructose corn syrup, because that was another one. I mean, we keep hoping that all we have to do is pop one pill or eat a lot of something will solve the problem. And it hasn't happened. We have good, I mean, will there be a magic breakthrough? We'll find out, but I'm not putting my retirement savings in a bet on that one. We know that there are barriers, that you can't just spend the entire session with a patient counseling about diet, because counseling about diet takes time. There isn't right now a great brief screener. Not everybody has adequate training about nutrition, but worse is that there's a lot of confusion about the recommendations, because there's ubiquitous misinformation. It is absolutely amazing what's on the web, and there's not a lot of time to keep up with the new trends. So it's understandable that there's a reluctance, but on the other hand, when you think about it, it's one of the most fundamental behaviors we have that impacts on health. So I just want to cite some of the reasons why we have so much confusion. So first is that the relative costs of foods and beverages, unfortunately, the ones that are most heavily advertised and the ones that are most heavily discounted tend to be the ones that we're trying to get people to stay away from. So this is, like an advertisement. And look at this. So, you have chips on sale, cookies, okay, crackers, brownie mix, chips, pudding, sugar water. Now you have the high salt ones, okay? And then you got up here, okay? So this is a problem, because this is essentially what you're working against. And, we just have to figure out how to get beyond it. But I think being aware of it is part of the issue, because you're aware of what your patients are seeing. And then there are all these health claims. Now, these are legitimate claims that can be put on food products. And I find the one that when I buy boneless, skinless chicken breast, I think the most interesting one is it's all natural. How could it not be natural? But that's what's on the label. That's what's, the consumer is seeing. And organic, organic apple juice for babies. Well, an article was just posted online yesterday, and it looked at early introduction of apple juice during the first year of life and subsequent preference for sweet foods when they got a few years older. Well, sure enough, they had a preference for the sweet foods. Why? But it was organic. And, so I think we have to realize that these things, again, the same thing with fat-free and with that. And here are some just other quick examples, but, mixed messages and inconsistent messages that there really are superfoods. Here's full fat milk with omega-3 fatty acids. We don't expect to get omega-3 fatty acids from milk, but do we really want to encourage consumption of full fat milk because it has omega-3 fatty acids. Here's, walnuts are good for the heart. This came out of the Predimed study. So just throw a handful of nuts into your yogurt, into your salad, into your breakfast cereal. And what you're doing is not substitutes. You're just throwing in a lot of calories. And that's not what we want to encourage people to do. So many times the message is, well, nuts are good for us and liquid vegetable oils are good for us. But the point is, what are you going to take out? You got to take something out, and somehow we don't get that message across. Oh, and then it's just so easy. There's this one dietary pattern. If you just go away from it, you cut your, risk in half. And it is, is it too good to be true? And what is the actual percent to begin with? Or you eat Cheerios for 6 weeks and you got a 4% lowering of cholesterol, which is in the, sort of within the range of analytical accuracy is not quite there. But these are the kinds of claims that you see. And then this is just a couple of my favorite ones. So this was a special, and it's just a Mazer cereal company. And it, it says it's high, so there's no high fructose corn syrup, no artificial colors, and no artificial flavors, in addition to which it is made with whole wheat, whole corn. So it's made with whole grain. Do we want to encourage this? Hopefully, no. Okay. So challenges to eating a heart-healthy diet. We also do have to realize, and this is part of the call to action, that there are socioeconomic factors and food insecurity that are barriers that are frequently not addressed that should be addressed. And part of it does have to do with structural racism and neighborhood segregation in underrepresented areas and ethnicities. And some of it has to do with food deserts and food swamps. I knew what a food desert was. It's hard to get fruits and vegetables in a place. I was not aware of the term food swamp. Food swamp is when you've just got lots of the kind of fast food outlets that you don't want people to consume in the deserts where you're not, and somehow desert and swamp, one's water, one's not, but whatever, you have the idea. And then unfortunately, there is also targeted marketing of unhealthy foods and beverages to specific groups that really are of the most concern. And we know this is, if you look at individuals with a higher income level or a lower income level, whether it be vegetables, and it doesn't, well, vegetables you can see, it doesn't matter, that the trend is the same, or fruit or whole grains, there's lower intake, whereas overrepresented is sugar sweetened beverages. So that's it. I hoped we'd have a lot of time for discussion, and hopefully we will. So these are the contributors to the 2021 updated dietary guidance, and these are the contributors to the rapid diet assessment. And I'd also like to thank Karen Freud for telling me or educating me about the Noun Project, because that's where I got almost all of the figures for this presentation. So thank you, Karen. Okay, so with that, so these are some of the things that I took this over the website of various, baseball, since I figured it's baseball season. This is what you can get, or it was pre-pandemic, this is what you can get if you went out to the ball game. These were the featured items. So with that, I'll take some questions.
There was a question in the chat that we can start with. Dr. Mason asked, although most, yes. Although most fruit juices do not have added sugars, they're still very high in simple sugars. So what do the data show in regard to whether diets high in fruit juices have a negative impact on cardiovascular risk?
Oh, so the fruit juice data are all over the place, and I think part of that is because adults don't really consume that much fruit juice. So it's whether but one would assume that a dietary pattern where people are getting a lot of their calories from fruit juice is probably not a good idea. But the data aren't there. Most of the data is from sugar sweetened beverages and the beverages with the non-nutritive sweeteners, and that's all over the place also because individuals that are heavier are more likely, well, there's a positive association between body weight and the cohort and the use of the non-nutritive sweeteners, but it's probably reverse causality because individuals that are heavier are the ones that are more likely to take it. So we don't really know.
Alice, when I was listening to your description of the 2021 recommendations, I had a serious case of the deja vus because they sound like very much like the previous recommendations. Can you distinguish between the old ones and the new ones?
Yeah, well, as an author of both of them, yeah, I can. I think now the approach, number one, the approach is different than we're talking about dietary patterns. And we're trying to put an emphasis on dietary patterns. And we really want to get to meet people essentially where they are and move them as opposed to just tell them what they should be eating. So that's number one. Number two, we are putting more emphasis on food processing because that is it's increasing, and there are projections as far as ultra processed foods and even a higher percentage of it being part of our diets. So we're putting more emphasis on that. And we're de-emphasizing this issue of, let's say, 10% of energy, below 10% of energy from saturated fat. Because it is virtually, and some people who argue should be 7%, should be 10%, 11%. It's virtually impossible to accurately calculate that, or there's less than 10% of energy from added sugar. I mean, we're real clear. We want to decrease added sugar. But when the new dietary guidelines came out in 2000, there was so much of the news coverage was that the scientific group recommended 5% and the government came out with 10%, where in reality, nobody can calculate it accurately. So we took the emphasis off of that. And some of it is just because some of these things are controversial. We summarized what the more recent data is to address the naysayers for some of these recommendations. And we also did mention about sustainability and environmental issues because we think about them now where we didn't think about it in 2007.
So there's another.
That was, well, I'm sorry, but just when I said there was, you know, I didn't want to think anyone to think that there were these major issues.
We have another comment and question in the chat referring to the infographic that features soy and canola oils, and the question is why not also call out olive oil to include in the heart healthy diet pattern? Yeah,
okay, that actually came in to us very quickly, that question, and we gave that as examples. Now, the olive oil is fine. Again, we don't want to split hairs. Is olive oil better than soybean oil versus corn oil? I mean, soybean oil has alpha-linolenic acid. It's the only commonly used plant oil that has alpha-linolenic acid. But any unsaturated oil, and also the issue of the data is stronger for polys than monos. But those were intended as examples, not as you shouldn't use olive oil. Olive oil is a great oil to use.
Hey, Alice, great talk, thank you. Two quick questions. One is, how does the U.S. do compared to, say, some other countries? You know, there are other societies that we could get some advice or guidance from. And then secondly, you didn't
wait, one at a time. As far as other Western countries, we're all having a similar problem. Unfortunately, the United States actually was a leader as far as rates of obesity and overweight, but now the other countries are catching up. They're taking different approaches, and the basic approach is the basic recommendations are the same, but it's sort of interesting because one of the things that we think about is, well, how can we communicate information? That goes back to teaching kids, but their labeling is very different. They frequently label on the basis of 100 grams of the food, which is an adjustment. And then they also, some of them have traffic lights or stars and those kinds of things that are absolutely mandatory. But none of the westernized countries are doing particularly well on this. Now, Finland had the North Karelian study. They actually had the highest rate of cardiovascular disease. That was from the Key study. And they conducted in one area of Finland, North Karelia. They sort of changed what was available in the supermarkets, and they had public health messaging, and they had anti-smoking campaigns, and their rates came down to the point that they then instituted across the country. So they subsidized lunch at work and free lunch at school, and it always has to meet their guidelines.
And my second question is about artificial sweeteners. So you didn't touch on it today. I don't know if the document provides any guidance. It certainly reduces caloric intake, but there may be some other adverse health effects, and it still has effects on insulin regulation and things. So.
Well, it's a hard one. It wasn't addressed in this document because it would need to be a separate one. It will decrease the caloric content of a food or beverage, but there's some data that suggests that there's compensation with something else that's consumed. But the biggest issue now with what's called artificial sweeteners and non-nutritive sweeteners and reduced nutritive sweeteners is there are so many of them. And we have to study them separately because we really don't know what the effect is, let's say, on insulin sensitivity or something like that. And people, we're not getting good data on it because people really don't have any idea. If you buy a diet soda or you have a reduced sugar product, you don't know what else is, what the specific ones are, and there are newer ones that are introduced. So it's something that needs a separate statement, essentially.
Hi, I'm first going to make a comment about the artificial sweeteners,
yes.
And then I have a question. This is based on a personal observation, but also to follow your comment that if you give babies very sweet things when they're younger, they'll like the sweet things. And my personal experience, so I actually had to come off aspartame because of a rash, and my taste buds changed. So I think another concept here, you're talking about dietary patterns, if we have less sweet things, artificial things are very sweet, will actually less in the future. And so I don't know how to study that, but I think just listening to the concept that you think about.
Well, actually, I have a doctoral student that's working on taste perception. We have, we're collaborating with the Predicate Plus study. And what we had originally reported is that if you measure all taste perception in all 5 tastes, so sour, sweet, bitter, umami, and salt, there's an inverse relationship between taste perception and it was, I think, waist circumference and BMI. So it seems that people have a total higher taste perception, they have lower, that they have better cardiometabolic risk factors. We then, what she's doing is she's sort of developed these algorithms for generating profiles, because we could have the same taste perception total, but let's say I perceive sweet very strongly and salt not, and use salt not, but sweet yes, you know, so vice versa. And what we're trying to do is understand how that's related now to cardiometabolic risk factors. Why? Not just because it's interesting, but because when we talk about personalized nutrition, we know in general advice is not, you know, it's just not going that well. However, if we could say to somebody, okay, you have a low perception of this and a high perception of that, and that's maybe why you're having a harder time giving up the sugar sweet beverage or something like that. So there's some work on sweet, mostly bitter, and I'm hoping more from my group will appear.
Excellent. I think another question from a personal perspective too was your comments on guidelines for children and in schools. My kids get, I think, horrible food in school, and I would love to be able to relate to the school from recommendations.
Well, yeah, I mean, that's the, my approach to that was I just sent my kids to school with lunch, and even in daycare, my son came to me and said, "Mom, how come I never get the good stuff?" And I also found out that now I think probably not because of nuts issues. There was an immense amount of trading and all those apples and clementines that I sent, I suspect did not go into them. But, you know, but I think it's a matter that you have to work at a school system level. That there's the federal guidelines. I mean, the last administration delayed the one about making mandatory the thing about whole grains. You remember during the previous administration, trying not to use names, it was a catch-up count and those kinds of things and vegetables. So it's public action. It's as with a lot of other things.
Thank you all so much for the talk. I want to call out the role of the dietitian. I appreciate that graphic. We absolutely agree that individualized counseling is going to be critical. I did want to answer Dr. Ford's question. As we're heavily involved in developing our electronic health records, there is a nutrition screen for all patients that needs to be completed within 24 hours. That's an automatic part. In terms of
like an automatic part of a regular well visit.
Yeah, well, no, an automatic part of an electronic health record as dictated by your clinician. Okay, so that's not necessarily geared towards cardiovascular health, but everybody does.
The registered dietitians do.
Registered dietitian, nurse, medical students, and anybody can complete that one. Yeah. But in terms of cardiovascular risk factors, as far as I know, it is not something that is automatically built in. There's a very comprehensive nutrition navigator that's part of Epic, but it's something that the dietitian would be potentially filling out in. I know that really we don't have access to a lot of this information. No, we probably have time to really proceed it, but it is something that we could definitely include if not now. That's something for the future.
It also could be a couple of doctoral theses and some good projects for fellows.
Absolutely, we would definitely have great opportunity to track. Thank you.
What tools or techniques have you found to be the most impactful in helping people of lower socioeconomic status be able to afford or like get the healthier options?
I'm a researcher and I'm mainly lipoprotein metabolism, so I've never counseled a patient or anything like that. I've actually learned a lot in the past couple of years where this issue has been raised, that if you can counsel somebody, but if they don't have the means and food insecurity, but you probably need a different speaker for that. Yeah.
Alice, I just want to thank you for coming in just before Thanksgiving. We'll see if we alter our dietary habit. I'm curious about well, I'll start by saying in the 90s, we talked a lot about caloric density. And there was a New England Journal article that said, you could have fewer calories if you ate twice as many carbohydrates as per gram of carb versus fats. And in the mid 1990s, late 1990s, we saw this spike in obesity, perhaps related to that. We didn't at the time realize the deleterious effects of that shift on actually lipids. And so I'm glad to see this shift towards food patterns, which seems to be more implementable and potentially less used in marketing in terms of no fat, low fat, but substitute salt or carbs for that. I'm curious at the policy level or the guidance level how that kind of played out to get that shift to happen and be incorporated into the new guidance.
Absolutely. So the reason, we went through this low fat craze, which was part of it. All the guidelines were less than 30% of calories is fat. And there was an unanticipated consequence. It was assumed that if people took fat out, they'd eat more whole grains and legumes. And there was the unanticipated consequence that there was a proliferation of fat-free foods that were made with refined carbohydrates, and the consumer was absolutely fueling it. So sometimes we blame industry. Well, it's a partnership between industry and the consumer. If the consumer buys it, industry is going to provide it. Anyway, we ended up with these new diets that really were high in refined carbohydrate and the foods that there was this misconception that it was low fat and low calorie. And suddenly people had permission to eat fat-free brownies and cookies and ice cream, all this stuff. And what did we end up with? Carbohydrate-induced hypertriglyceridemia. We had all the sugar flooding into the liver. The liver couldn't retain it, exceeded the capacity of peripheral tissues to take it out. So what does a liver do? If it's a healthy liver, it makes it to fatty acids and puts it out into VLDL, and we have triglyceridemia, and then the HDL goes down also. It was the data. that it essentially the theoretical of just decrease the caloric density of the diet didn't work. So now people talk more about volume, but what we found is there's the Towns Law study, there's the Diet Fit study. These are really long intervention studies where a high-fat diet and a low-fat diet, no effect on body weight. It's just the data are really clear. So in 2000, actually, dietary guidelines for Americans changed from less than 30% of calories is fat to moderate fat. The Heart Association changed, and then we had INSEP, the National Cluster Education Program, also shifted to moderate fat. So it was a lesson learned.